So we will start the access with the Palmer's point. This is called Palmer's point. That is mid-clavicular line just below the costal margin. 2 centimeters below the costal margin, mid-clavicular line. So this is Palmer's point. Because she has the incisional hernia, so we should enter with the Palmer. She has two hernia. One is here also in the ultrasound. Another is big here. So we will enter with the Palmer's. So this is the costal margin. We can palpate here, and we will put it here. This will be our varicella. So this is Palmer's point. So we will give one a small stab wound, only 1 millimeter stab wound. That's all. After that, we will take the varicella. Narrow gastric tube is must. You should have. And direction of your varicella should be right towards the stomach. It should not be down. You should try to perforate the stomach. Then it is easy. If you will try to save the stomach, you will perforate the splenic flexor of colon. And here you will get 3 click sound. This is one click, that is aponeurosis of external oblique. This is second click, that is aponeurosis of internal oblique. And this is third, which is peritoneum. After that, we will take a syringe. And this is irrigation test. You can see it is easily going. And then aspiration. And nothing should come, only bubbles should come. And you can see there is a ball there, which is floating. Can you see? After removal, it should sink down. This is called hanging drop test. That means you are inside the abdomen. And then we will attach the tubing of insufflator and we will start insufflating. And within first 5 seconds, insufflator actual pressure should be single digit. And we can see this is single digit. If it is single digit, that means it is correct that you are inside the abdominal cavity. So we can see if it is double digit, that means you are not inside the abdominal cavity. So you can see it is single digit in 5 seconds, not immediately. And preset pressure is 15, actual pressure is slowly increasing and flow rate is 1 liter per minute. And you can see total amount gas used is right now 500 ml. So this is called quadromanometric indicator. There are 4 indicators in quadromanometric. First is preset pressure, second is actual pressure, third is set flow, and total amount of gas is right now is 0.9. After 1 liter of the gas input, you can increase the flow rate to 3. So we can see 3.6 liter of gas has already gone and actual pressure is 10. So she will take approximately 15. So approximately 4.5. So 15 will reach up to 4.5. So this is now filling up. We can see we have given only 1 millimeter stab wound over the inferior crease of this mid-clavicular line. Only 1 millimeter. Some people have a habit of giving the large incision. Problem of giving large incision, a lot of gas will keep on leaking by the side. Can you see that? So this is only 1 millimeter stab wound. Now 15 is reached. So now we will take the various needle out and then we will enlarge the incision to 11 mm. This is 11 mm. After that, we will go with the trocar and direction should be towards the stomach. Narrow gastric tube is must and it is in. After that, this is hissing sound. We will enter inside with the telescope and have a look. So now telescope is inside the abdomen. So it looks good. There is no much adhesion. You can see hernia here. Either side hernia is there. Either side, this side also, this side also. Can you see that? There is one hernia. Either side there is hernia. So light only check karo. Right side. So this type of hernia is called Swiss cheese hernia. We will do the diagnosis. One hernia in here. Just to inspect the abdominal cavity, we can see this is little adhesion. And we are using harmonic to just, this is omental adhesion. And we can see right and left both the side hernia. And both the side inferior epigastric, one is on the lateral to inferior epigastric vessel on the left side, and right side medial to inferior epigastric vessel. So this is a type of Swiss cheese hernia on the right side. And first thing what we have to see that we should distend the bladder. This is right and this is the left hernia. And we will distend the bladder so that we can enter into the space of radius, because the mesh has to cover all around and we cannot put the mesh on the bladder. So mesh should be in between the bladder and anterior abdominal wall. So we are distending the mesh. There is a Foley's catheter. So through the Foley's catheter, we are putting approximately 500 ml normal saline, and you can appreciate the distension of the bladder, and bladder is distended. So advantage of distending the bladder is that once you will separate 2 centimeter above the delineated dome of the distended bladder, and then bladder will weigh down. Bladder will weigh down, and you can make the preperitoneal space, and you can open the space of radius, so that mesh should go on either side of the Cooper ligament, and then we can fix the mesh anterior to the bladder and posterior to the abdominal wall. So left hand is stretching the peritoneum down, and with the harmonic we will open the space of radius. The advantage of laparoscopy is that once you will open this space, automatically CO2 will enter and it will help you to make the space of radius. Always take care that fat belongs to bladder, so you should be anterior to the fat, and then bladder should be way down. So here is some scar of the previous Caesarean section. This patient has developed hernia after Caesarean section. So this type of hernia nowadays is very common with the increasing incidence of Caesarean section. And we can see peritoneum is dropping down, and slowly fat belongs to bladder, so you should keep the fat down. And this is the retropubic space. Bluntly with the 2A traumatic grasper, you can drop the bladder down. And this preperitoneal pocket has to be enlarged, so that in this space we can drop the mesh. Here we will put half the mesh preperitoneal and half of the mesh will be intraperitoneal. This is the inferior epigastric vessel of the right side. So bladder is dropped down, so we are safe now. And with the harmonic, little bit more peritoneum will be lateralized. Medially also peritoneum will be extended laterally. But care, this is inferior epigastric vessel of the left side. So care should be taken that inferior epigastric should not be injured. Further lateral dissection should be carried out and peritoneum should be dropped down. So this is all blunt dissection. You can see Cooper ligament of the right side is visible and left side also is visible, and we are in the space of radius now. Pubic symphysis is visible and peritoneum is fully reflected all around the defect. So now dissection part is over. We have a sufficient space to put the mesh that will cover the either side of hernia. And we are using here tie mesh. This is a very strong titanized mesh that has advantage that it can have the preperitoneal area also, and titanized mesh has less chances of adhesion with the bowel. So this is tie mesh. We are putting it into the retroperitoneal area and spreading it all around the defect, and it should either side go to the Cooper ligament as well. So it will be pushed in and spreaded, and now we will start fixing it with the anterior abdominal wall. For that we are using the tacker, and this tacker will fire. Care should be taken that tacker should not accidentally fire over the inferior epigastric vessel. So either you should fire lateral or medial to the inferior epigastric vessel. And left hand should support the tip of the tacker while you are firing the mesh. So we can see mesh is covering all around, and it is going at least 4 centimeter lateral to the outer margin of the defect. This is lateral to inferior epigastric vessel. We have to be careful. You can fire over the breeze of this Swiss cheese type of hernia, but we should avoid firing over the defect. Now inferomedially we will fire over the Cooper ligament either side, and we cannot see the Cooper ligament, but once you will go to the Cooper ligament you can feel the hardness and you can move the patient. You can see here patient is moving. That means you are at correct place. So it is hard. That is the Cooper ligament. It may be pubic tubercle, but we are little medial, little lateral to the pubic tubercle. And this is done. This is the right side of Cooper is fired, and the left side of the Cooper also will be fired. And now this peritoneum of the bladder we will fix over the anterior abdominal wall. At this time we will open the clamp over the Foley's catheter So while you are firing, slowly bladder will getting deflated, because now the gravity of the fluid in the bladder will prevent you fixing the mesh. So we are deflating the bladder, and this edge of the peritoneum will be fixed with the anterior abdominal wall. We can see some of the part of the mesh is exposed, that is not covered, but that is fine because this is a titanized mesh. So that will not create any problem, and the bladder is getting now deflated. And this is important that we should support this peritoneum to the anterior abdominal wall. So there should not be any internal herniation, and any bowel or omentum should not enter in between the bladder, and it should not go to the space of radius. At that time, little bit pressure of pneumoperitoneum also you can decrease, so that there will be no any tension over the bladder. And now surgery is almost over. Slowly gas will be taken out and the abdomen will be deflated. So thank you very much for watching this video. Have a nice day.